Well, sweet. Thanks for coming in, Josh.
Yeah.
Can you just, for everybody's information, just explain what you do, kind of what your background is, how you got into it?
Yeah. So simply put, like 20 years in public safety, ranging from Air Force security forces, a lot of time in healthcare security, but some time in youth corrections and even behavioral health services out in the community. So as of right now, last couple of years, I've been the Southern Region Crisis Prevention Instructor.
Okay.
So teaching a certain line of content there.
Yeah.
Mostly focused de-escalation. And, of course, in the ED, sometimes we need physical interventions if they become a danger to themselves or others.
Right.
Right. So, yeah, it's kind of my trauma-informed job now, definitely.
Yeah, one reason I wanted to talk to you is just because this is a topic that comes up a ton just on the podcast in general. Like the ER is a very unique setting. We deal with all kinds of aggressive behaviors from patients. A lot of times it's alcohol, it's drugs, even occasionally when they're just really not happy with the care and they don't understand kind of the limitations of the ER, and like even, folks that are addicted to opioids and we don't treat their pain adequately, or we say, hey, this is really not an appropriate reason to give a narcotic to you for this particular thing you have going on. And that really riles people up. So even the patients that aren't psychiatric or on, intoxicated or on drugs, even those patients escalate on occasion. And regardless of what you do in the ER, down to the techs, the EKG people even, you have to have some level of ability to de-escalate people and know how to talk to people, because a lot of times they're just not happy with our care. They don't have anything emergent going on. They're going to go home. They're not happy with the lack of an answer. And even in those small interactions, you have to learn how to talk to people, to explain, like, we don't always get a clear answer. We're here to make sure you're not dying, and make sure that they're content at least with that answer. So that's why I thought it'd be an interesting discussion, just because it's pertinent to everybody, not just security. Even at the clinician level, we need to know how to de-escalate people, and we get no training in that. Medical school, PA school, they don't teach you how to talk to people. They don't teach you how to de-escalate people. And, and it's not the patient's fault. This is often the worst day of their life. They don't know what's happening to them. They don't understand the ER. So not that it's their fault in every situation, but we need to know how to talk to people, on the worst day of their life, or what they've perceived as the worst day of their life. So totally.
And I'm excited. I'm hoping we are exploring opportunities. Some of our heads of department come out of the ED, including our docs, right? Yeah, they alluded that to us, like, in all their years of education, possibly a decade plus, they did not receive anything like my course. So, we're hoping to explore opportunities there, because that's huge. Yeah, sometimes I've had docs start code grays, or, just because it's how they said it, right? Like, this isn't appropriate for the ED. This isn't life or death. But what the patient's hearing is, I'm not important. We have this grown man crying in tears, in pain. And, in that instance, I believe he just wasn't acute enough to be rushed back. So the memo he's getting, he wasn't important enough right then. I'm like, could we given him a lower level intervention, real quick to appease him, and just set it a little different? For sure.
Yep. So much of it is
because we did solve it by talking. He didn't leave AMA. He didn't hurt anybody. Most of the code grays are just handled by verbal and.
Explain what a code gray is too.
Yeah, thanks for asking. So it's getting nationwide recognition, just about, but also other departments have known it as a behavioral health emergency response, or code BERT, as we called it back in the day. But it's just to cover our gray areas when a teammate needs more resources. You see safety's breaking down. Hopefully, we're using it before active violent behavior. That's distress behavior. What is it? What distress is it communicating, right? A basic need or a want. So let's gather up that team, a multidisciplinary team. So you activate a code gray, you're going to get, I've been in a few different agencies across the state, and your average code gray is going to have security, your physician, maybe charge nurse, house supervisor, and there's been other organizations that maybe include, pharmacy in there or others. A lot of times we'll get spiritual care show up to ours. So then hopefully whatever we got, whatever the patient or family needs, hopefully we have it.
Mm-hmm.
So you just need the boss lady, here's our house soup.
Yeah.
You need Jesus, here's your guy.
Yeah.
Or you think you're Jesus, here's our behavioral health team.
Yep.
And if none of us can talk sense into you, well, then maybe here's our security team to maybe show you the door.
Mm-hmm.
Potentially, just because, at least that's why I'm back with our organization over my little journey, is just because we put staff safety first, and then patient safety will follow. You remember back in the day, we used to do whatever it takes to stop somebody who is, a danger to themselves or others. But just what's the point? Forcing that care usually doesn't help.
Yeah. Yeah, the climate's changed a lot. Even when I was a paramedic, I mean, we would break into people's houses routinely, and the police department would help. They would help us break in. Even if we know they're the sole occupant of the house, they called or they texted somebody and said, "I'm suicidal, I'm going to kill myself," and that would give full license to break into their house. The cops are helping, even though it's not a criminal offense. And we'd break into people's houses, we'd tie them up, throw them on the cot, and force them to go to the ER, which probably was not really helping people. Right. Do they need help? Yes, but in different methods than that.
Yeah.
And then there was that case, you're probably familiar with all this, but there was that case in Boulder. I think they tased someone in their home. It was a scenario where they were the sole occupant. Police department forced their way in. I think they tased them, and at the end of the day, they caused some kind of harm by forcing entry into the house, and caused more harm than good by doing that. And that kind of reset all of the local law enforcement to say, unless there's a criminal aspect to this, we're not forcing our way into people's houses anymore. We're not putting them in handcuffs. We're not forcing them to go to the hospital. And EMS has a slightly different role. If someone is actively suicidal, there's some room for them to force someone to go to the hospital. But from the law enforcement perspective, they're usually very hands off and like, hey, we're not going to cause more harm to this situation. And
exactly. Because, what was it doing for the patient or the citizen? What did it do for the police officers? Mm-hmm. They're facing burnout like the rest of us too.
Yeah.
Right? So if it didn't do them any good, didn't do us any good, why'd we do it?
Yeah.
So what was our reasons back in the day for tackling that patient on an M1 hold trying to leave?
Right.
Off the top of your head, what do you think a couple of reasons where we might have tackled an M1 patient?
I mean, I would assume what was going through our minds at the time would be they're going to go kill themselves. They're leaving the ER because we think they're going to go do something to harm themselves, or potentially someone else, if they're endorsing homicidal ideation. So I would assume in the back of our minds, we're tackling someone to prevent them to go out into society and do harm to someone else or themselves.
And that was exactly most of our justifications. But so we're doing it for public safety, but whose job is that? 911.
Yeah.
So let's let them handle that if they can safely do it, right? And we know 9 times out of 10 it is just words. Mm-hmm. They're just trying to take control back of the situation,
right?
So what's our job? Is we're here to provide excellent medical care if it's safe to do so. Mm-hmm. And it's simple as that. If it's not safe to do so, then why are we taking it so far?
Yeah.
So that's why we're really trying to advocate, across the state, really, to call those code grays early. Let's get the team gathered sooner than later. Or even better, we're using something called the Stay Safe Huddle, right? Because maybe we've seen Steve 5 times this month or this week, right? We already know his patterns. Why wait till he acts up again, right? We can just, hey, Zyprexa worked amazing last time. Let's go ahead and get that on board right away, right? Have security on standby right away, but we know he didn't like this security officer, but he did like this one. Let's have her come over or whatever, right? For that person-centered approach. You just never know.
What are good scenarios to call a code gray?
So back to trauma-informed, I can't say what fear is to you or what a safety breakdown is to her or them. So it's on the individual. If you think you need more resources, you see safety's breaking down, you see a power struggle going on, stop power struggling, step out, get some help.
So it's not like it's not like you're ringing a false alarm. If you feel unsafe, you feel like it could deteriorate, just call it.
Because there was sometimes fear culture, more so in other organizations than ours right now. But they're like, I don't want to call it code gray. I don't want to. Well, yeah, they're not going to come beat up our patients. Even before revamping code grays and CPI 2 years ago, over half of the code grays did not end hands-on. So we just hope to actually see more code grays and then spread that gap of staff injuries, less restraints. Yeah.
So the priority with the code gray is let's make sure everyone providing the healthcare is safe in this scenario first.
Yes.
Secondarily, how can we help this patient? Do they need just somebody who's a little bit better with words to explain what's going on? Or sometimes patients, especially those with psychiatric illness, pick certain people that they will not get along with no matter how things are worded. And then they'll find somebody else that they're okay talking to, even if it's the same words.
Yeah.
Sometimes they kind of fixate on certain people. And so sometimes getting somebody else in there is just better.
Yeah. Both we're often well-spoken, but yeah, maybe they had trauma with guys with red beards.
Right.
So this ain't for us today, man.
Yeah.
Right. So I'm going to go find a teammate that maybe resembles the patient. There's comfort in being had in just talking to somebody who looks like you. Can you not put orders and options through a tech, through a sitter, through a security officer?
Yeah.
Right.
Right.
Why not?
Right. Yeah. And just this, and I think recognizing that too is important, that not a lot of us have that skill set. But I know as a clinician, I know when things are not going well. I know when I'm starting to get emotional, and that's a big red flag. Like, okay, I feel like I'm not even being the professional I should be. I'm going to step out and let another provider go in and try their hand at this. Not even necessarily call a code gray, but this interaction is not going well. I'm starting to feel it. If I'm starting to feel emotional in a job where I should kind of be above the fray, I should be a little detached in a lot of scenarios. If I'm now getting emotionally involved in this, maybe I should step out and reevaluate here when things aren't going well.
Exactly, right? Just sometimes we got to tap out, ask for help. And I mean, that's what we're trying to get to the patients. Just accept help, ask for help, right? Because sometimes that's what that distress behavior is. Usually just an unmet need or want. We'll ask staff in class is like, let me see a show of hands. Who in here has chose to break the speed limit? It's all right. I ain't going to tell on you, right? And almost everyone. And yeah, I'm going to pick on the ones who don't put their hands up. I'm like, really? Sure.
Right.
Like, okay. All right. I'm like, so why did you choose to break the speed limit? Like, oh, I was running late. Need to use the restroom. Need to get this day over with. All right. That's a need. Or because I felt like it. Had a rental. Want to drive it like I stole it, right? It's a need or a want. All behavior is a need or a want. If we can... And so then I'm like, violence is a form of communication. So what do you think violence communicates? And we'll bounce around the room like, life falling apart, stress, bills, this drama, that. And I'm like, sure, yeah, we're complicated creatures, but if we boil those issues all down to their simplicity, it's coming down to an unmet need or want.
I like making that simple. That's a good question to be able to ask yourself to reevaluate instead of getting in the emotion of the moment, getting caught up in the same emotions the patient's having. Like, what is the need or the want here that is not being met? And how can we reevaluate and kind of meet that? That's good. I like making that more simple.
Yeah. Not in the old school sense. You remember Patch Adams, right? Oh, love that movie. I know it dates us a little bit, right? But remember, starting out in the movie, he was overly detached. Physicians walking around. He was like, all right, 31-year-old female patient, cancer, yada, yada. And he's just like, how are you? What's your name? So, like, we still need to have a basic human connection, yet still somewhat simple. Don't allow their behavior to overly influence ours, right? Try to rationally detach.
Yep.
Don't make their problem our problem.
Right. Yeah, that's a good point. That's something we talk about on here all the time is, like, finding that line of there should be some healthy detachment. We can't bring home everyone's burdens with us. That's not healthy, but it's also not healthy to view them as patients and not human beings that have needs and wants. There's a line in there that you have to find, and if you're swinging too far on either end, that's going to burn you out, and that's going to provide not good health care to people.
No. Nor, then why do you work? Do you live to work or do you work to live?
Right.
Sure, I love my job. I love helping people. But most of us, it sounds like a cliche, but we care too much. Yeah. So, but so if you're swinging one way or another, you're caring too much or not enough. All right, I'm ready for the fight tonight. Let's go.
Right.
Then, that's your sign that might need some help, right? It's becoming permanently transformative.
Yeah.
So, kind of just keep that thing in check, right? I try to use this stuff on my kids too, right? Try not to make my teenage daughter's problems my problems, right? Yeah. Just like this could be the worst time in her life. You never know.
Yeah.
You never know which moment is going to fracture that, so to speak.
Yeah, a lot of those things do cross over to raising kids because kids are hard too. And it's like, unless, some of us that have done any kind of training in de-escalation. I had some when I was a paramedic. I've read books, like verbal judo, things like that. Like give people options, don't tell them what's going to happen. Give them options and allow them to choose because people want a choice. And that's true with little kids, if you give them choices like, hey, you can walk to your room or I'm going to carry you there. But, you're taking a break from this activity and that goes over well, then you're going to your room, and forcing them to do something. A little kid is often like a drunk person a lot of times, and now you have to handle them.
It really is. It really is. Or in other cognitive disorders too, right? They're living with dementia, living with special needs. Be like, I bet this is scary. But I was like, all right, I'm going to keep the scary people back. Stay in bed. Show me safe behavior, I was like, keep your hands to yourself. And I was like, all right, do you want to take, and if we are at that tipping point, they've already shown that they're a danger to themselves or others. I'm like, okay, I'm going to give fail-safe options. I have 2 teammates behind me ready to, keep them in bed, get them tucked in. But we're going to go ahead and offer them one more choice to take meds by mouth or injection. And it's so surprising how often they'll be like, all right, I'll go ahead and take it.
It gives them that little piece of control when they feel completely out of control and like we're forcing them to do all these things. And sometimes we are, Yep. If they're a danger, we are forcing them to accept healthcare when they may not. But if you give them that little choice, it gives them just that little piece of control. We talk about it with even like the physical exam. We don't just walk in a room and start touching people. I'm like, hey, is it okay if I feel your abdomen real quick? You're having abdominal pain. Is it okay if I feel your abdomen? And that gives them that little bit of like, okay, people aren't just coming in here sticking IVs in my arm, doing a bunch of stuff I don't understand. Like even that simple little thing, it gives you consent to actually not to examine somebody as opposed to assaulting them. And so I like that little verbal, yes, it's okay if you examine me kind of a thing, but it also gives them that little aspect of control. Like, yeah, I'm okay with being touched, especially in our world now. I feel like a lot of people don't get physical touch maybe as often as years past. And so you coming in and just starting to touch them can be a little disorienting to people, even just to do a physical exam,
Exactly. Because we're in this mental health pandemic. People, not just kids now, all people are stuck on video games, getting instant gratification in these virtual worlds, right? So now all of a sudden, we're touching them, we're forcing things, they got to wait for things. Yeah, so sometimes they just need a little more support, reminded of their options. Yeah, like even, we've just rushed into vitals before. I had an EMT get their tooth knocked out.
Yeah. I believe it.
If you just took a little more time, like you could have seen his ABCs were secure from across the room. And taking a little more time to partner with the Spanish-speaking family and find out, this was a nonverbal mid-20s male, non-compliant with his meds for the last 2 weeks. He's probably going to have some sensory issues. Right, so let's come up with a plan. I bet we could probably still make a safe approach and safely handle this. But all of a sudden, we're in the middle of a fight with a really big boy.
Right. Yeah, it's hard to remember that sometimes. I think so many people get very task-oriented, and you're like, especially the techs, they got to go in and get vital signs on 100 people a day. And they go in and just start doing that. And 95% of the time, it's probably fine. But you have that 5% of people that are like, what? You're not even telling me what you're doing. And so it's worth kind of getting in the habit of approaching people a certain way and explaining what you're doing and getting that quick permission of, hey, I'm going to put this on your arm. It's going to squeeze your arm. And then you kind of you take that extra couple seconds to realize this could be a problem for this patient when you take that extra second to kind of explain what you're doing.
Yeah. I mean, the class starts out with how you introduce yourself. Because just because what you said, we get so task oriented. We drop so many social norms when we come into the hospital for some reason, and we just rush up to people and start touching them.
Yeah.
And I'll demo it in class. I'll rush up to somebody, and I'll go to reach out to them, not touch them. I'm like, how would you react if you're in the park or you're at the mall and someone just started touching you without your permission?
Right.
Right. Like, yeah, it make you defensive too. Like, so slow your roll a little bit. I know we like to turn and burn, especially in the ED, but it's really going to add to more progress if we take a little bit more time to introduce ourselves. Right. It's even more progressive to spend 45 minutes just talking to them than it is to, all right, let's squash this. But then in 5 minutes, 2 people get knocked out, another staff has a broken rib, and who knows what happens to the patient. That's not really helping progress now, because now we have all those open shifts that got to be filled in. The rest of the staff left over are now burnt out.
Yeah.
Right.
And that's exactly, I think that's the biggest part of this is those negative interactions that go horrible. Somebody gets kicked, somebody gets punched. Like, those negative experiences will stick with you so long, especially compared to, we have a lot of positive experiences. I was talking about this the other day, that we don't tend to remember the positive ones, but those negative ones, especially the ones that get violent, that's not going to leave your mind anytime soon, and that's going to burn you out so much versus taking that extra time to make sure a situation de-escalates. And especially de-escalating a situation successfully can prevent burnout, because you're like, hey, I did a really good job with this person. I took the extra time it took to sit at the bedside, look them in the eyes, and figure out what they want from this interaction as opposed to what we want from the interaction. The volume is so high at all of our facilities. It's very easy to just focus on throughput and, hey, you're not dying, you're going home. But it doesn't help the patients in the long run. They're dissatisfied with the care. They're leaving angry. They're going to go to another hospital where they feel like they can get better care. And all that would have prevented that is just sitting down and taking that extra time to explain why they're safe to go home. Here's the follow-up plan. And it's easy to let that stuff go by the wayside when you're getting really busy and you're seeing a ton of patients. But it's so important to actually sit and take that time. That's one thing I try to work on is, like, instead of standing in the corner of the room with my hands crossed, why are you here? What's going on? And then doing the same thing when I go to discharge them. You're not dying. You're going home. Instead, sitting down, not that I have to be in the room for 20 minutes, but sitting down, looking them in the eyes, explaining a couple things. It doesn't take that long to actually make a patient feel reassured in the right way.
Yeah. It's huge. And I kind of had I've diversified my background quite a bit over the years, after healthcare security, went into youth corrections, dislocated my ankle there. I was like, man, I was at a loss. I was like, what do I do? All my jobs always required me to be fit to fight, and I got to figure something else out now. And yeah, I could have been angry and salty with the situation, could have dove into addiction because I had to be on oxy to control the pain and the swelling. But I was like, all right, what am I doing when I'm not fighting? I guess I'm coaching. So I found myself in youth and family services out in the community. And I got to support both systems, whether it was those stuck in the cycle of mental health or the cycle of corrections. They often intertwine. And honestly, they just needed peer support, some community connection. And it was huge for both of us. It was like I was like in recovery physically and emotionally alongside them. Because it's like, yeah, I'd get gangsters just to go to the gym. I was like, I heard you like football. You maybe want to get in shape for that again? You're like, I guess. All right. And we would just maybe go through the motions. You see the trauma reactions darting around the room, all nervous. And I was like, hey, you a little worried? You look a little worried. Yeah. I was like, hey, everyone's here worried about themselves. And I was like, so this is time for you to worry about yourself. Yeah, you're still surrounded by the community. And then they start seeing me run into AMR friends and fire department friends, police department friends. Like, hey. And I was like, I was just showing them community connection was I really was aiming for.
Yeah.
And that was huge. Then we got them to start listening to professionals. Once I start getting a little sense into them, I was like, all right, now listen to your doc. Listen to your mental health provider. Listen to your probation officer. Right? Just kind of. Because it happens to all of it. We all lose touch with it. And at some point in time, if we don't, keep that in check, keep it balanced out. Like, so sometimes you got to step away from the ED for a little bit.
Yeah. No, that's a great point. People are so isolated these days. If you don't have a community around you, you can't trust anybody. And then you come to the ER, we have a very limited time to establish rapport with you. And if we don't even take that second to establish some kind of rapport, when I go to tell you the plan or tell you something emergent is going on, you have no trust in me at all. And so you're going to leave against medical advice. You're not going to believe me when I tell you this is an emergency. We're going to keep you in the hospital for this. Or on the opposite side, you're not dying. They're not going to believe me if I've not done any time to establish rapport. And if they have no community outside, if they're very isolated, then they don't trust people anyway. So building that community is huge.
Yeah. So like you said, you don't need 20 minutes in the room, maybe 5 more minutes to talk about some of these resources. If they want to talk more about it, you can hand them off to, one of our social workers or behavioral health. The nurse can talk about it. Who knows, right? Anyone really could talk about the resources at that point.
And it's great when we have the ability to give those resources and have social work involved. We probably underutilize them still, even though they're always saying, hey, we are available all these hours, please utilize us. Because there are so many patients where you're like, hey, I'm putting you on antibiotics for this. And they have no means to go to the pharmacy. They have no means to purchase these antibiotics. Something that would be simple for you or I to go get a prescription is a huge barrier for a lot of these people. And there's a lot of resources in place for them for simple things like that.
And our most at-risk population usually qualifies Medicare, Medicaid. And so when they would get attached to peer support like me or whatever it was, I could drive them over to the county building, get their social security card, get a birth certificate again, start getting their life back in order, start getting their benefits rolling if they don't have those in place. If they're living with special needs, I can get them with the resource exchange, so on and so forth. I would just really kept pointing them in the right direction where they needed to go and try to guide them through that process. Sometimes it's really simple.